Welcome back, everybody. This is Dr. J and GC bringing you another episode of Q&A with Dr. J, all about genes and how they impact us and how we can impact them back through lifestyle choices. And first of all, knowing what genes we have that are working inside of us so that we can feel better about why we are the way we are, right? There's a lot to be worked with, and one of the first things I would have to say is knowing what you've got going on makes a whole lot of difference in how you live, what lifestyle choices you make, how you feel about yourself. And today we're going to talk about something that I know lots of women fear. Men have concerns as well because it affects men and women, and that is osteoporosis, the dreaded porous bone syndrome. And I never really thought about how genes would affect people's greater or lesser tendency towards brittle bones and porous bones. But Jay is going to help us understand how they do impact us.
Yeah, very much. There's a very big component when it comes to osteoporosis and osteopenia with the genes. There are certain specific genetic variants that can contribute to it big time. One of them is, of course, the vitamin D receptor. And a lot of women and men too take vitamin D and calcium, thinking that that's going to be the thing, that they know that vitamin D helps with bone health. Maybe they're not sure why, and that you need calcium to build bones, when actually that can be a very dangerous combination. When you take vitamin D and calcium together, British Medical Journal has shown that I can actually increase cardiovascular risk because it starts to deposit calcium in your arteries and joints and kidneys because the body isn't sure where to put that calcium. So you have to have certain nutrients in there that tell it where to go. So let's start with that vitamin D receptor, and I want to share a study here. This is from a National Library of Medicine, PubMed. Genetic influence of vitamin D receptor gene polymorphisms on osteoporosis risk. And if you look down here, the VDR polymorphisms, API1 and TAC1, were found to be significantly determinant risk factors for osteoporosis progression in the Saudi population. They only studied the Saudis, but turns out we're 99.9% the same. So it's going to be the same, but they have to declare that. But when we look at the genetic variant, so this vitamin D receptor, this is the receptor. So if you have a genetic variant there, that receptor is closed. Vitamin D can't get in there very efficiently. You may, if you have a genetic variant like I do, homozygous, both parents gave me the wrong code for that one, taking vitamin D is not going to work because the receptor doesn't open up and accept the vitamin D like it should. And so this is where I started with understanding genetic variants for me, because as we talked about in the past, it's involved in how we make dopamine and serotonin. And my vitamin D levels were always really low. No matter how much vitamin D I took, I couldn't seem to get my levels to go up. And when we look at, again, some of the risks of genetic variants here, it's a pretty high risk, including rickets and hyperparathyroidism and cancer and dental issues, chronic infections, degenerative disc disease, hypercalciuria, etc. But yeah, a big connection with osteoporosis. And how do we work with that? And this is where I started looking at how do we get that to change? Just because you inherited that genetic variant, like, sucks to be you, or can we do something with that? And that was where our team in my clinic, we did a deep dive into, let's look at how this receptor works. How do we get it to function better? How do we upregulate it? And we found the cofactors. And so once we found the cofactors, we got the enzyme or the receptor to open up. D can get in. And then all of these things start to happen downstream. And one of which, for me, my depression went away because my brain suddenly could make dopamine and serotonin. And that was a big deal, but it also impacts your ability to fight infections through activating T cells. It gets rid of small intestinal bowel overgrowth. But a big part of this is now the body can take in minerals, including calcium, but all the other minerals as well that are critical for making bones work correctly. And so when we started working with this, we saw bone density start to go the other direction, which was really cool. So one of the cofactors is K2, and K2's superpower, if you will, is that it tells those minerals that you're absorbing, it tells them where to go in the body. So out of the carotid arteries or the other arteries so that you don't get calcification, and into the bones, into where we want it, out of the joints, out of the kidneys, out of the arteries, into the bones. And that's where we saw, oh, look, you can't measure bone density very quickly. It's usually about 3 years before you can do a repeat test on DEXA. But you can also see, are you losing bone or gaining bone through a urine test where you can see, are we going the right direction or not? But we have some before and afters where we saw the bone density start to go in the right direction, which was fantastic, along with all the other benefits of vitamin D, which is huge. There are other genetic variants there too. Let me share my screen again. There's one named after you, GC.
Really?
It's right here.
Is it a nice one?
It's a nice one. It's
Oh,
the
good.
best. This is the vitamin D binding protein, and it's linked by several studies to vitamin D serum concentrations. Variants are associated with lower vitamin D. Again, it can contribute to low vitamin D status, COPD, type 1 diabetes as well. And then there's the BCM01, and this one converts beta carotene to vitamin A. So you have a genetic variant there. You can't take a vitamin A source, and that's the other cofactor. So K2 and A open up the receptor, D gets in. I'm going to caution you not to do that unless you know what else is happening downstream, because you're going to turn on all kinds of things downstream that you may not know what's going to happen. I'll address that in a minute. So we look at these genetic variants, the retinoid receptor, how well do you absorb the vitamin A? The protein, the vitamin D absorption is here, the receptor's there, and then the ability to convert beta carotene into vitamin A is there. So all of those can contribute to low vitamin D status and low vitamin D absorption. So when we get your gene test back, we're going to look at all of those things and design a program specific around how do we get those going and how do we prevent osteoporosis, because it's nasty. And as we age, we get weaker and et cetera. So we will look at that combination. But if you do go out and go, I'm going to go get the K2 and the A and D and start taking that, you just started the body making more dopamine and serotonin. And if you have genetic variants in the MAO or the COMT gene, you're going to send yourself into irritability and anxiety. So that's the difference with our company, is we look at not just one gene. We're not going to focus on one gene with you. We're going to look at the whole pattern, the whole picture here, and see where you have these genes together and this gene. Now your program is designed for this. And so it's a symphony essentially, and it's important to look at the whole picture.
So I need a clarification. You didn't mention calcium in any of those pathways, but
Yeah.
we all, as you mentioned at the beginning of the video, think we need to take calcium. Is there any benefit from the right amount of calcium if it is balanced with these other things? Do they all work together better if they have calcium?
My opinion is a little bit controversial. If you take a look at calcium, it is ubiquitous in the diet. It's everywhere. Green leafy vegetables, in meats and proteins and eggs, and not getting calcium is a trick. In my experience, most people have enough calcium. It's all about, are you sending it to the right places? And you have the cofactors, and magnesium is a big one. If you're not taking enough magnesium, calcium is not going to be absorbed correctly. And the other cofactors for building bone, boron and silica and all the other minerals, are super important too. We focus so much on calcium,
I
and
know.
it's a really disservice to understanding the whole pathway there. The other piece of this is hormonal. So as we age, especially as women go through menopause, our levels of hormones go down. So there's these two hormones, blasts, actually they're not hormones, they're cells, osteoblasts, osteoclasts. The osteoblasts build up bone, osteoclasts break it down. And so a lot of people are using the bisphosphonates to prevent the osteoclasts from breaking down bone. And at first, logically, you'd say, that's a good idea. Instead of breaking down bone, we want it to build up. And so let's kill off the osteoclasts. When you do that, you've just destroyed the ability of the body to remodel bone. Those osteoclasts break down old diseased bone. Now you've disabled them and you're going to have thicker bones. Yeah, it's going to look thicker on a DEXA, but it's weaker and more brittle because you aren't breaking down the old diseased bone cells, the osteocytes. So it's not really an ideal thing to do. And people are noticing that they're walking along, they've been on bisphosphonates for a number of years, and suddenly something breaks, just walking along. Their jaws start to have issues, they'll break a bone, and it's like, where did that come from? I've been on these osteoporosis drugs. So for me, I just would caution you to look into it a little bit deeper. And I know there are new innovations there, and now some people are doing injections of these drugs, and just look into the side effects and the long-term repercussions. Does your DEXA look thicker bone? Yeah, but it's not always better bone. And so back to the hormones, progesterone actually builds up osteoblasts. It increases bone production. I would suggest that you go to your integrative healthcare practitioner and get your hormones tested, because the estrogens and progesterones are critical for keeping bone healthy and building up the right bone cells and getting your risk of osteoporosis reduced.
Yeah, thank you. I remember doses when I was maybe in my 30s of 1,600, 2,200 a day of calcium,
Yeah.
which seems the RDAs are ridiculously low, but that seems like a way over what's needed daily.
Yeah. Yeah, it's tricky. And I think we tend to just make it simple. And that's true of a lot of things in our lives. We go, okay, I got osteoporosis, I'm going to take calcium. And it just is not the whole story. There's so much more to the puzzle. And looking at the vitamin D receptor is a big piece of it. So when you get your genes tested, look at, do you have genetic variants there? If so, then we can work with that and get your absorption of vitamin D. That would be my first step. And look at your hormones, get your hormones tested, and figure out whether or not you need some. I'm fond of the bioidentical, and I think you and I have talked about that
Yeah.
before with people if their hormone levels are so low. But also, when we look at the genetic variants, it's really interesting. We get the body making hormones correctly. So I'd like to do a Q&A on that.
Okay.
How the body makes its own hormones. We think that we have to micromanage everything, and that's just not the truth.
This is the truth. We don't need to micromanage everything. But I guess that really would be easier said than done unless you have the knowledge, the tools to do otherwise.
True, true.
Anyway, people, don't forget exercise. Shout out to the bone
Oh,
building
yeah.
exercises
Yeah, there you
in
go.
case you're thinking of how to build your bones. Anyway, very interesting, this whole calcium conversation. I'm glad we had this. So anybody listening, watching, please share this video if it's going to help somebody else with their concerns about, or whether like your sister or somebody that you love is downing their calcium caps every day and it isn't balanced with magnesium, K2, all those things, then just have them watch this and do a little research, as Dr. J said, because I know that cancer patients, certain types of estrogen positive receptor cancers, the drugs will increase bone loss. And so the doctors will say, take this for 2 years. Let's just do it for a short term. I think a short term makes more sense than forever. But again, everybody's individual. Just ask your practitioner what the side effects are and how long you could be on a drug before you experienced those. Yeah.
Yeah, just do your research. And that's what these videos are all about, is empowering you to ask questions. Like, okay, is this really, I'm hearing that there are some adverse kinds of things that can happen with this drug. Can you tell me about that? Or doing your own research and making sure it's good research. If you go to Google Scholar,
Yeah.
you can find the actual studies, and it isn't just some guy's opinion or some woman's opinion, whatever. There's a lot of opinions out there on on any subject that you want to look at. But if you want more scholarly articles and better information, go to Google Scholar and look and do in there.
Yeah. I love Google Scholar.
Yeah, I do too.
All right, Jay, I guess we'll be back again next week with another Q&A.
All righty. Good to see you, GC.
Good to see you too. Take care, everybody.